Good afternoon, everyone, and welcome to this edition of Jaipur Surgical School, which is an online educational activity as an extension of the Jaipur Surgical Tutorial, which we have been running for last 3 years at the Mahatma Gandhi Medical College and Hospital in Jaipur. That activity is being coordinated by my colleague, Dr. Anand Nagar, who is an associate professor of HPB surgery and liver transplant at my institution. And this activity of Jaipur Surgical School, which was specifically started on the request of colleagues and students from Africa, because they could not attend the Saturday morning activity, is being coordinated by Dr. Piyush Vashne, my colleague at AIMS Jodhpur. In this educational program, we consider various surgical topics, but from time to time, we invite colleagues from related departments to cover some important topics. And in that context, we have covered chemotherapy, radiation, and several other issues. And today, we will have a discussion on ABG, arterial blood gas analysis, which is an important component of the monitoring of any critically ill patient or any patient who's undergoing a major operative procedure. To deal with this topic, the speaker is Dr. Anand Jain, who's in charge of our liver transplant ICU. He looks after almost 4 to 5 liver transplant recipients in their early and immediate post-operative period at my hospital. And to chair the session, we have Dr. Avnish Bhardwaj, who's the head of anesthesia, looking after a large number of theaters in our 1400-bed hospital, which includes various specialties and super specialties and a large MD anesthesiology training program. So with that, I hand over to Dr. Avnish to moderate this session and then Anand to present. I am busy with another institutional academic activity, so I may log out for some time, and Piyush will continue to look after the session. Dr. Avnish, please.
Yes, sir. So good afternoon, everyone. ABG analysis. ABG analysis is actually something which everyone should be aware of, how to use it, where to use it. It's actually a basic investigation which can be done by bedside. So my presentation here is going to be for ABG for beginners only. So I consider everyone as a beginner. Even I was a beginner at some moment of time. So do you all, so are you guys. So what is meant by ABG? Simply, it's arterial blood gas analysis. The goals for this talk are that we are going to provide an approach to interpret. We are going to provide an approach to interpret ABG analysis, that is the acid-base disorders. The goal of this talk is not going to teach the physiology of any respiratory gas exchange or to debate on any alternative approach for how to interpret an ABG. ABG as such is any other study. Whatever we read, learn, has got a systematic approach. As required for an ECG interpretation, a systematic approach has to be taken care of while reading an ABG. There are no shortcuts for it, reading an ABG. And if you fall for it, you are not going to read an ABG appropriately. And at the end of the day, you will be landing up with nowhere. So not helping your patient out. This is a simple picture depicting how does an ABG look like. As you can see up over here, that there are many various things which has been mentioned, like for an example, at what time the ABG analysis has been done, what is the ID of the patient, when was the report generated. Then there comes our various values, which like pH, PCO2 and PO2, which are actually measured by the arterial blood gas analysis machine. And then comes a certain corrected values for a temperature specific. This temperature, which like in this case, it's 38.6 is what we enter in the ABG machine at the time of its analysis. Whenever we are entering these data, we have to be particular that we actually enter the right values into it so that the corrected values can be extrapolated. But if we enter them wrong, will it make a difference? So the answer is going to be No, because we are actually concerned about the measured values. Then comes is the calculated data. The various data which you can see up over here, the bicarb, actual, standard, base excess, these are all which are calculated. Many of them are useful to some of us, but actually all of these values are of importance. We are not going to go into various details about these values because they are going to be beyond the base ABG interpretation for an individual. And at the end, the entered data, what we have entered in the ABG machine. So, whenever we put this blood sample into an ABG analyzer, the ABG analyzer has got various things. It uses the traditional methods. There is a pH electrode which measures the pH of the solution which has been inserted into the ABG machine. What it does is it actually compares the pH of the solution which has been inserted into the ABG analyzer and compares it with the pH of a standardized solution. And after comparison, it gives a value. What is the pH of this particular solution or particular, say, blood, whatever we have actually entered in the ABG machine. Then comes is PCO2. For PCO2, what happens is the carbon dioxide which is produced in which is actually present in the blood, it undergoes a chemical reaction to produce hydrogen ion. The hydrogen ion which is produced causes a difference in potassium, which is measured by this electrode as the pH is measured. Then is the PO2. For PO2, it uses a polygraphic device that measures the oxygen tension by oxidation reduction reaction. It is a chemical process that generates measurable electrical currents. There are various other optional things like oximeter, sodium, potassium, calcium, chloride, and hematocrit, which can also be measured with this ABG machine. Now, to understand it further, one should know what is meant by acid-base balance. So, to understand acid-base balance, the first thing is what is pH? pH is actually the power of the hydrogen. Or it is a simplified way of expressing the large changes in hydrogen ion concentration and is expressed in negative logarithmic scale of hydrogen ion. Our body actually maintains the homeostasis by acting on this acid-base balance to maintain a pH within a narrow range of 7.35 to 7.45. The various buffers which helps in maintaining this pHs are lungs, kidneys, and blood buffers. Now, our machine is going to read this. How does it do? It actually reads it using certain formulas, and these certain formulas or can also be used to understand the interaction in the body, which is expressed in the form of Henderson-Hasselbalch equation. It actually describes the fixed interrelationship between pH, PCO2, and bicarb, and can be depicted as pH is equals to pKc multiplied with log of bicarb and divided by dissociation of carbon dioxide, or in simplified way is the pH is equals to bicarb divided by PCO2 with kidneys and lung acting as buffer to this. The bicarbonate here is measured using this Hasselbalch-Henderson equation. Big complicated, isn't it? It's similar to like Einstein, he can read the maths, but he is not aware that what a women understand. So, making it easier for you surgeons, let me ease out things. The normal pH of the body is between 7.35 to 7.45. The compatibility of life is maintained between the extremes of pH from 6.8 to 8. If it goes beyond it, there is a possibility that the patient is going to die, or it's actually leads to, if the pH of these extremes are present, the patient is going to die. Now, if we move further, we should be aware what is acidosis, what is alkalosis, what is acidemia, and what is alkalemia. So acidemia is if the pH of blood is below 7.35, it is called as acidemia. And if it is above 7.45, it is called as alkalemia. A process which leads to a decrease in pH beyond 7.35 is called as acidosis. It could be respiratory or metabolic. Similarly, a process which will lead to increase in pH to more than 7.45, it is going to be called as alkalosis. That could be respiratory or metabolic. Right? Now, to understand it further, what is an acid? What is a base? And what is a buffer? An acid is a substance that releases hydrogen ion when it is dissolved in a solution. Thus, it increases the hydrogen ion concentration, and inversely, it decreases the pH. As for example, carbonic acid, it releases hydrogen ion. For bases, it's going to be reciprocate. It is going to accept the hydrogen ion when it is dissolved in solution, and thus a decrease in hydrogen ion concentration will appear as an increase in pH. Bicarbonate accepts hydrogen and we are well aware about it. So it is a base. What is a buffer? A buffer is a substance which can either accept or it can release hydrogen ion depending upon the surrounding hydrogen ion concentration. Thus, it resists the big changes in hydrogen concentration, or you can say it acts as a sponge which absorbs whatever is given to it. So in our body, the buffers are the various buffering systems are the backup buffer, the lungs, and the kidneys. For example, for lungs, what happens is if the pH has gone down, so there is going to be metabolic acidosis to compensate it. What would lungs do? They will actually exhale out carbon dioxide to maintain a pH between the physiological pH of 7.35 to 7.45. And similarly, if the PCO2 rises, the pH is going to fall. Then in those cases, the kidneys comes into play and they will excrete excess of hydrogen ion through the tubules in the form of ammonium. Now, to understand it further, we should be well aware about the normal values. So the normal values, as you can see, are for pH, it's 7.40 plus minus 0.05, that is 7.35 to 7.45. For PCO2, our range is 35 to 45, which is called as normal, and for PO2, it's 80 to 100 millimeters of mercury. When we go for backup, the range is from 22 to 28 millimoles per liter. The normal oxygen saturation of a healthy individual is always going to stay more than 95. Now, if you want to read an ABG properly, you should have certain habits of successfully analyzing the ABG. What are these 7 habits? The first is one should be aware whether the ABG which he or she is reading, it is authentic or not. Once you have established the authenticity of the ABG, then comes as whether the acidemia is present or the ABG is having alkalemia. If it's acidemic, whether it's respiratory or is it metabolic. In case if it is respiratory, then comes the third step, which is to recognize whether it is acute or chronic. If in either of the cases, if it is acute or chronic, there is going to be a compensation for it. Whether this compensation is adequate, that is, the metabolic compensation is adequate according to this, and the pH which our ABG analyzer is reading, is it adequate, or there is some additional acidosis which is present to it. And if there is metabolic acidosis, then whether the anion gap is present or not. And if the anion gap is present, whether is it high gap metabolic acidosis or there is a gap. We're not going to go in the details of the last 2 steps, so we will restrict ourselves to the first 5 steps only. Okay, so first thing is checking the validity of ABG. So for checking the validity of ABG, one has to calculate the hydrogen ion concentration. As we have already talked about the Henderson-Hasselbalch equation, the pH is equal to 6.1 plus log into backup divided by 0.03 into PCO2, or to ease out things, hydrogen ion concentration in nanoequivalents per liter is equivalent to 24 into PCO2 divided by bicarbonate. In ABG, we have already seen that the PCO2 and bicarb are measured, so we can calculate the hydrogen ion concentration through it. And the negative logarithm of this hydrogen ion concentration is going to be the pH. So if the pH which is mentioned on the ABG is equivalent to the pH which you have calculated, the ABG is called as authentic. But it's difficult to remember that how to convert this negative logarithm to pH. So we can't keep the tables of logarithm with us. So to ease out these things, I'll give you a simple formula. It is called as rule of 80. So what does rule of 80 say is that post to the decimal places deducted from 80, and whatever is the value, that is going to be your hydrogen ion concentration. For example, 7.00, that is 80 minus 00. In this case, the hydrogen ion concentration would be 80. If the pH is 7.05, the last two digits are 0.05. So we are going to deduct last two digits from 80. That is 80 minus 0.05. That is equivalent to 75. That is our hydrogen ion concentration. To calculate it further, ideally we have to multiply it with 1.25 or 0.8. That will give us the actual hydrogen ion concentration. But this is good enough to go ahead with. So you can calculate the pH and you can check whether the blood gas analysis is authentic or not. Now comes the step that was step 0. Once the authenticity has been established, then we are going to look whether the ABG is having acidemia or alkalemia. If so, we will take a look on the pH. If the pH is less than 7.35, the patient is acidemic. If it is more than 7.45, then the patient is alkaline. Easy. Now comes is the difficult part. Whether is it respiratory or is it metabolic? So for acidemia, if the pH is low and the bicarb is less than 20, supposedly the pH is 7.2 and the bicarbonate is say 50, it is going to be metabolic acidosis. But in case if the bicarb is normal or maybe increased, then have a look at the same time at PCO2 as well. So for PCO2 more than 40, if it is more than 45, then it is a respiratory alkalosis leading to this acidemia. Similarly, in cases of alkalemia, the bicarb is going to be more than 28 or for metabolic alkalosis and less than 35 millimeters of mercury of PCO2 for respiratory alkalosis. Got it? Okay. Then comes the primary or secondary acid-base disorder. Or to ease out things, if there would be the body will try to establish a normal pH. So if there is going to be a change in the primary, there is going to be a secondary change as well to maintain this homeostasis. So for the case, if the patient is having respiratory acidosis, the PaCO2 will increase. At the same time, the bicarb will also increase right, to maintain the pH. But if it is respiratory alkalosis, then the PCO2 will drop and so will be the bicarb. In cases of metabolic acidosis, the primary changes into the bicarbonate, that the bicarbonate declines and it causes the PCO2 to come down. So to maintain the homeostasis, the body will excrete out carbon dioxide. So the partial pressure of carbon dioxide into the blood will come down. And for metabolic alkalosis, it's going to be vice versa. So as we have seen, for every primary disturbance, there is going to be some secondary changes which will come into picture. Now, if the next step is to identify whether the problem is acute or chronic, if it is a respiratory acidosis. In this case, what you need to understand is, or what you need to derive is, what is the pH. So for this, we need to calculate the pH which should be expected in this condition, or a delta pH. Delta pH is the change in pH. So for delta pH, we will calculate it by multiplying 0.08 into delta PCO2. So delta PCO2 is going to be PCO2 up, which is mentioned on the ABG, minus the normal PCO2, that is 40 we have taken. We should take, and we will divide it with 10. In case if it is going to be chronic, then the change would be 0.03 into delta PCO2 divided by 10. Now, whether this primary disturbance has got a compensation or not for respiratory acidosis, if it is less than 24 hours, then the change in bicarb is equal to 1/10 of the change in PCO2. But if it has lasted for more than 24 hours, the body has been given a time to compensate. So in that cases, the change in bicarbonate is equal to 4/10 of the change of PCO2. In case of respiratory alkalosis, that it exists for more than 1 to 2 days. If it is lasting for 1 to 2 hours or more than 2 days, makes the difference. If it has lasted for 1 to 2 hours only, then the change in bicarb is 2/10 into delta PCO2. And if it is more than 2 days, then the bicarb is going to be changed by 5/10 of the change in PCO2. So to ease out things, it's 1 and 4 for respiratory acidosis and 2 and 5 for respiratory alkalosis. That is the renal compensation for every change in PCO2 level. Now, if you have established it, if there is no respiratory acidosis or respiratory alkalosis, then you need to check that the disturbance is metabolic or not, and the respiratory compensation is appropriate or not. So for metabolic acidosis, the expected PCO2 is equal to 1.5 into bicarb plus 8 plus minus 2. That is called as the Winter's equation. And for metabolic alkalosis, the expected carbon dioxide concentration would be 0.7. That is almost the half of what is in metabolic acidosis. 0.7 into bicarb plus 21 plus minus 2. If it is not, or actual PCO2 is more than expected, then there is some sort of hidden respiratory acidosis. While if the actual PCO2 is less than expected, then there is some hidden respiratory alkalosis which is present. To understand the metabolic acidosis, that comes as, what is the anion gap? Anion gap is sodium minus chloride plus bicarb. I'm just saying it so that if you are interpreting an EBG and you see a metabolic acidosis, you can actually make out whether the metabolic acidosis has got a anion gap, high anion gap, or normal anion gap. So a difference of sodium minus chloride plus bicarb is actually anion gap. If it is less than 12, this is usual. If it is more than 12, then high anion gap metabolic acidosis is present. And what could be the reasons for high anion gap metabolic acidosis? So there is a mnemonic called as mud piles. What is mud piles? M stands for methanol, U stands for uremia, D stands for diabetic ketoacidosis, P stands for paraldehyde, I for any infection or lactic acidosis, and E is for ethylene glycol, and last S is for salicylate. Okay. The last step is to understand what is anion gap and what is does the anion gap explains the change in bicarbonate or not, whether it is purely high anion gap metabolic acidosis or it is associated with another associated metabolic alkalosis, or is it associated with normal anion gap acidosis. So we calculate anion gap, that is measured anion gap minus normal anion gap, and we also calculate the change in bicarb, that is normal bicarb and the measured bicarb. And we will simply divide it. If it is equal to 1, then this is a pure high anion gap metabolic acidosis. If it is more than 1, then there is some association with metabolic alkalosis. And if it is less than 1, then it is associated with normal anion gap metabolic acidosis. So let's come down to certain examples. So a 30-year-old female with a history of sudden onset of dyspnea, no cough or chest pain, her vitals are absolutely normal, but has got a higher respiratory rate, that is 26, and she is anxious. And this, you ask for an ABG, and this is an ABG report, which you can see up over. So the pH of this patient is 7.5 to 3, PCO2 of 30, PO2 of 105.3, with a BICA of 23.9. At first instance, what would be the first step? The first step is we should check whether this ABG is authentic or not. So for this, what we are going to do is we are going to calculate the hydrogen ion concentration that is expected, and we will compare it with what is measured. So in this case, if you take a look, so the expected hydrogen ion concentration is 80 minus 52. 52 is the last two digits of the pH. So we deducted it, and the answer is 28. But what is the measured hydrogen ion concentration in this case? So for measuring hydrogen ion concentration, it is going to be 24 into PCO2 divided by BICARB. So when we did it, so the answer is 30. So is this ABG normal? So there is some error in this case. Ideally, it should have been within the range. Let's come to another case. This is case 2. He is a 60-year-old male smoker with progressive respiratory distress and presents with somnolence. And the pH says that the ABG says that the pH is 7.301 and PCO2 is 76.2 with a PO2 of 45.5 and a BICARB of 36.1. So let's come down to first step. We have checked the authenticity in this case. We will move ahead. So the pH is less than 7.35. So this is acidemia. And the direction of pH is declining and PCO2 is increasing. So this is a respiratory acidosis which has led to this acidemia. Now let's check whether the is it acute or is it chronic. So for that, we will calculate our delta CO2. So for the calculation of delta CO2, it's 76.2 into minus 40. We will take it 76 to ease out. That gives us a value of 36. If it would have been an acute respiratory acidosis, then the change in pH would have been 36. That is what we have calculated, divided by 10 multiplied with 0.08. So that gives me a value of 0.29. So a change, what should have been the expected pH? That would have been 7.40 minus 0.29, that is 7.11. So this is definitely not a acute exacerbation or acute respiratory acidosis. Then we have to check whether it is chronic respiratory acidosis or not. So for chronic respiratory acidosis, the delta pH is going to be 36 divided by 10 and it has to be multiplied by 0.03. So as per the calculation, it would be somewhere around 0.10. 12 divided by 9, that is approximately 0.10. So the expected pH would be 7.40 minus 0.10, that is 7.30. So this is quite near to this. So this is a chronic respiratory acidosis. Once we have established that this is a chronic respiratory acidosis, we need to know whether an adequate compensation is present or not. So we will check for the change in BICARB concentration. Since it is a chronic process, so we will multiply it with 4 divided by 10 into change in PCO2. Change in PCO2 we have already calculated, that is 36. So 4 divided by 10 into 36, that is equivalent to 14.4. So the bicarbonate should have the highest limit of 24 plus 14.4, that is somewhere around 38.4. Since this is quite near to the actual bicarbonate, so this is a pure respiratory acidosis. Now comes is the case 3. In case 3, we have got a patient. He is an 18-year-old male. He is asthmatic with 3 days of cough, dyspnea, orthopnea, not responding to usual bronchodilators. And on examination, the patient has got respiratory distress, supraesternal and intercostal retraction is present. He is appearing tired and is on 4 liters of oxygen through nasal cannula. And he was asked for an ABG. So the ABG says that the pH is 7.232 with a PCO2 of 60.1 and a PO2 of 66.3, and bicarb actually is 24.5, and he's maintaining a saturation of 92% at a FiO2 of 30. So first step is to check the authenticity. We have checked that. Now coming down to second step, that is the pH. Is it acidemic or alkalemic? It is acidemic. Now again, respiratory or metabolic. So PCO2 is more than 45, so it is respiratory acidemia. Now comes is acute or chronic. So we will check for the delta CO2, and here it is going to be 60 minus 40, that is delta CO2 is 20. And in case if it is acute, so delta pH is going to be 20 divided by 10 into 0.08, that is 0.16. So the expected pH would be 7.40 minus 0.16, that is 7.24. So this is acute respiratory acidosis. Since we have established that this patient has got an acute respiratory acidosis, we are not supposed to go further on to check whether a chronic respiratory acidosis is present or not. So we will directly go on to the next step, that is to check whether the patient has got a respiratory acidosis with metabolic alkalosis or there is an underlying metabolic acidosis as well. So we will check again the delta bicarb. So we checked the delta bicarb, that is 1/10 of the delta PCO2, and delta PCO2 was 20. So 110 into 20 is 1/10 multiplied 20 is equal to 2. So the limits of bicarb is 24 plus 2, that is 26. So it's approximately in the normal range. So this patient has got respiratory acidosis. Is there any metabolic acidosis? No, there is not a metabolic compensation which is present. So the metabolic acidosis has to be present. We will check for the anion gap in that condition. In that condition, the sodium, if supposedly in this case is say 140 and a chloride is 100, then the anion gap is going to be sodium minus chloride minus bicarb, and bicarb we already have. So sodium is 140 minus chloride is supposedly 100 and then 24. So this is 16 and it is more than 12. So is it normal? What do you guys say? So if we recapitulate our previous slide, if the bicarb is less than 12, it is normal. If it is more than 12, then this is anion gap metabolic acidosis. So this patient is having an underlying metabolic acidosis with it. Coming down to our next case. This is a 28-year-old diabetic patient with respiratory distress, fatigue, and loss of diet. Again, let's start with case 4. So a 28-year-old diabetic patient with respiratory distress and fatigue, she presents to us in emergency. And when we look at the ABG, the pH is 7.236 and the PCO2 is 34 with a PO2 of 110 and a bicarb of 14. So if we look, we have already established the authenticity. After establishing the authenticity, we checked whether this is acidemic or alkalemic. So it's acidemic. The pH is less than 7.35, but the PCO2 is 40 and bicarb is less than 22. So this is a metabolic acidemia. So in this case, we need to check what would be the metabolic, what would be the PCO2. So we will calculate it according to the formula which we have given, that is the Witter's formula. That is going to be 1.5 into bicarb plus 8 plus minus 2. So as we can see, 1.5 into 14 plus 8 plus minus 2, I have done the calculations. You can check. So 1.5 into 14, that is approximately 21. 21 plus 8 is approximately 29. So 29 plus minus 2. So that is 27 to 31. So ideally, it should have been between this range, but it is more than that. So this is some metabolic acidosis with an underlying respiratory acidosis. Then comes is the calculation. If it is metabolic acidosis, we have to understand whether it is NN-gap metabolic acidosis or low NN-gap metabolic acidosis or normal NN-gap metabolic acidosis. So we will check for sodium and chloride, and the values of sodium is 130 and chloride is 100. So we will calculate the anion gap. That is going to be 130 minus 100 plus 14. That is the bicap which we have got from the ABG. So the anion gap is 130 minus 114, and again is more than 12. So this is going to be a high anion gap metabolic acidosis. Now, once we have calculated the high anion gap metabolic acidosis, we will check what is the gap. So what we will do is we will also calculate the delta bicarb. So delta bicarb is bicarb, that is normal. 24 minus 14 is equal to 10, and 4 divided by 10, it is less than 1. So this indicates that the patient has got a non-gap acidosis. I hope you all guys have been able to understand the basics of ABG and would be able to interpret post this session. But to end with this, everyone wants to know whether we can keep this PPT with themselves or not. So there is no copyright on this material. One can copy it for the educational purposes. And thanks to all for not becoming committers. And I hope you will be able to read the ABGs from now onwards. Thank you.
Dr. Anand,
Yes, sir.
first let me congratulate you for making this difficult to understand topic easy for our audience. And you have made it very lucidly clear that for the life processes to go on, all organ systems should function properly. And then for that, you need the right milieu and right homeostasis. And that is maintained by your body buffers and two organs, that is lungs and kidneys. Lungs responsible for short-term, minute-to-minute changes, and kidneys for long-term changes. You also explained how the compensation takes place in such situations in acute and chronic disturbances. And with the help of well-selected cases, you have explained how to read and interpret the blood gas pictures obtained, whether it is authentic or not, and what is the type of disturbance, whether it is a pure disorder or it is a mixed one, and so on and so forth. So you have really made it really easy to understand. Now, the house is open for questions if there are any, though you have explained it so well.
Thank you, sir.
So we have some
I
questions.
hope I did the justice to the presentation.
Technical glitch, I couldn't join you immediately on start. There was no audio, somehow there was some technical glitch. So do we have some questions in the chat box?
Right now, there are no questions, sir. But
Okay. Okay, Dr. Bias, nice to see you.
thank you, sir.
There was some technical glitch, so couldn't immediately join at the beginning of the session.
Yes, sir. I think just to comment upon that, it was a very good discussion about the ABG, because especially for the beginners. As a surgeon, like I can say, interpreting ABG is not that easy, like we take it so easily. So my advice is like every time we see the ABG, we should also interpret it. Not only just see the ABG and leave it for anybody else to interpret it. So as a surgeon,
Certainly.
also, we should try to interpret it and discuss it with our colleagues that whether the interpretation is right or wrong. Then it only comes into a habit. Otherwise, all these things keep out of habit if you usually do not interpret it.
That's right. I fully agree.
ABG interpretation requires a day-to-day practice. Whenever you are seeing an ABG, just go through it, and over a period of time, you will expertise. And that would be a take-home message. So all what is required is reading an ABG every day. The more you would do,
Now, one point I would like to add here that when you see and interpret the ABG, you need to consider the serial ABGs, and you should keep it in the background, interpret it in the background of the clinical scenario which you have been observing. So that's pretty important. The course, clinical course the patient has taken, and the serial ABGs. Like an ECG, we need not take a final call on one single ABG. For example, if we have resuscitated a patient who had a sudden cardiac arrest, and soon after resuscitation, the picture will be different, and after lapse of time, it may come to be normal. So disturbance is only at that point of time. Secondly, the common practice which has been observed is that people do not write that when the sample has been taken, what is the state of the patient. So they need to mention the hemoglobin and the temperature. And this is important to mention that what is the FiO2, how much is the FiO2, whether the patient is breathing spontaneously, patient is breathing air or is on oxygen or is on ventilator, with what kind of FiO2. That will help you in properly interpreting the ABGs. So that is one practical point which I think, and certainly when you interpret the ABG, you must consider that the sample has been collected properly, has been transported quickly, and it is ideal to have ABG machine close by in the user area, because transportation and taking it like that, it makes a lot of difference. During collection, if you take some air, the PO2 and other values are going to change. So when you look at the serial ABGs, all these things are also eliminated. So I would say that serial measurements are important, particularly in a chronically sick patient who is in intensive care unit. So if there are no questions, can we end the session with a vote of thanks to Anand, and good job done by Piyush for all of us.
Yeah, sure, sir. I also thank you and Dr. Anand for sparing the valuable time and giving the input, especially for the students. Thank you, sir.
Thank you, sir.
Thank you, sir. And thanks to VK Kapoor, sir, as well, for giving us this platform so that we can reach out to the students.
I've just joined back. Thank you, Anand. Thank you, Dr. Avnish, for your contribution. Thank you very much.
Thank you,
Thank you,
sir.
sir.
Thank you.